Good morning, everyone. Rob Bart, Chief Medical Information Officer at UPMC.
Yan Chow, Global Head of Healthcare at Automation Anywhere.
I'm Mike Mosquito, Head of Enterprise Automation and Integration at Fox Rehab.
Great. So Rob, tell us what the hell is agentic AI?
I think a practical definition or a practical use case for me is it's so first of all, AI is not a solution, right? And agentic AI is a subset of AI that's a specific tool to serve a specific function to perform a task and execute that. But it can perform that task in an intelligent manner. We've examined using sort of in the clinical decision support space, inserting agents in there that can help contextualize decision support so that the false positive rate of the decision support firing can be tuned better so that physicians and or other clinicians pay more attention to the decision support.
Mm-hmm.
If you have a high false positive rate, then the likelihood that someone's going to tune in and pay attention to what that decision support is asking you to do is lower. Having some intelligence embedded in there, in that agent, allows some, we're using it to get some context of the end user, right? Because decision support typically has the context of the patient, but it typically doesn't have the context that I'm not just a physician, I'm a pediatric intensivist who's logging in. So something that needs to fire to alert me might be different from my colleague, the pediatric surgeon or the pediatric cardiologist. Or someone asked in the previous session about trainees, the alerts might need to be different for someone who's an intern versus a resident versus a fellow versus a senior physician. And so we're trying to interpret context of the user to tune the decision support in a much higher fidelity of it. So that's sort of one framework and how I've been able to think about the use of agentic.
Sure. And when you think about it, how would you differentiate it from just old-fashioned scripts, old-fashioned plugins, extensions, et cetera? Is there more ceremony around it, and that's why it's important, or what makes them different?
So old-fashioned plugins, I think of those as much more as being very traditional deterministic.
Mm-hmm.
And so it can only interpret a simple set of input and only give that singular yes or no output for the most part in the simplest case. This actually allows some interpretation to go on the input to add some to contextualize it in the use case that we have, such that there's a little more personal information about that allows the output to be tuned more to the context of what I might need to see.
Mm-hmm.
As a pediatric intensivist, I might be the alert around the creatinine increasing might be much more pressing for me than it might be for a general pediatrician, given that patient, it also has the context of the patient's on medications to improve their blood pressure, right? So those types of things, it allows a little bit more of interpretation that adds to the value of output to me as the user.
Mm-hmm. No, that makes sense. So yeah, you guys have been at Automation Anywhere. You've been doing this for a long time. In the old days, robotic process automation, automation in general has been, obviously it's in your name, so it's an easy thing to understand. But when we think about large language models, it's a request response system. You ask something and you get something back, right? So Rob's taught us now that in these particular areas, potentially you don't have to ask anybody anything. It's watching for events and then interacting on those. How does your experience in robotic process automation fit that mold? And then what do you guys think of agents?
I think it's an evolution that's ongoing, and it's even for Automation Anywhere. I think it's a 22-year-old company. And somewhere around 2016 is where we started to pick up machine learning in OCR. And then 2020 was when we started to go to AI and sort of Gen AI. And of course, 2022, ChatGPT came out and everybody was talking about Gen AI. And today we're in AI agents. We're rated as one of the leaders in AI agents. And I'm thinking, I agree with Rob, but technically, an AI agent is goal-driven as opposed to rules-driven. It's like telling somebody, do this, this, versus telling them, achieve this, no matter how you want to do it within constraints. And so it's been a really interesting transition. I think there are a lot of issues we'll talk about with AI agents, but it's been a wild time in healthcare.
I think it's a great way of defining it is to just say, don't tell me how to do something, just tell me what to do. Mike, do you agree with that as a framing?
I agree. It's framed with guardrails, right? As John said, it gives you that path of, I need you to go accomplish that goal. Whatever path you need to go to source it, get that information to achieve it. Now, it's validation of, did it achieve the goal with the right information, and is it delivering upon that goal with accurate data on the back end, right? Because it could tell you, yes, I achieved that goal. Is it accurate in the summary? It's like math, right? Many different ways to solve a problem. AI does the same thing. It's going to try to get as many resources pulled in to achieve that goal. Right, wrong, or indifferent, it's going to try to get to that goal. What I didn't announce during the beginning here is that I'm also a co-founder and partner for an AI company. And we have contracts with Humana, Blue Cross Blue Shield, and a mental health organization for responsible gambling and mental health. And we are using our engine is being used to solve what we're talking about here. And when you talk about in mental health, you've probably seen some of the ads on TV for the crowd out here, where if you're having an issue right now, please call. And they have these agents now on call 24 hours a day that you can talk to. And it's a bot, but it sounds like a human, but it's a bot on the back end. Now, the problem with how that started is that, I guess now it'd be 4 years ago now, this company decided to come out with a bot for mental health. Person called the line. They were in dire straits, severe dire straits. The bot did not have an answer. The person put in the queue, I feel like jumping off a bridge because I don't see a way out. The bot replied, you probably should. This was captured. It was in the news. Remember this. The bot actually responded that way because it didn't have another path. As Jan just said, it solved the problem, right? Because it had a finite amount of information. That was captured. And so now when we talk about guardrails and responsible agents, that's what we're talking about, because this becomes a reality when you start putting these bots in places of human intervention and human care. And so, yes, it's going to accomplish these tasks. It's going to give you and resolve the answer that you've asked it to resolve. But what was the end result? So that's why we there's a cautionary tale. Automation is going to be beautiful for us with the right guardrail.
Yeah, I totally agree. So Jan, let's set that stage and say, well, what are the top issues? Because everybody, in general, I don't think people are disagreeing that agentic AI is the way to go. This goal-oriented approach that you talked about is the way to go. But what I'd like for you to do is just say, okay, the top 3, 5, 6, whatever issues that you guys see as you're doing implementations at scale. What are those problems with agentic AI?
I think we're still in the early days of AI agents. And so a lot of health systems are bringing in many AI agents. And what that leads to is
What does it look like? I mean, is there a box like somebody puts agents in and you walk them in? What does that look like? Tell us what that means.
And so not only is that fear, doubt, and confusion in the market, but there's a lot of experimentation. So that leads to the next question which is, how do you orchestrate? How do you manage? How do you govern? And, the main thing about healthcare systems is they're very averse to risk because they're so, healthcare is risky. And so there's many things to talk about when you talk about what you should let an agent do or not do. And there are many factors to consider, but I'm thinking these days with all these agents that human committees are not going to be able to do this. That's a huge change also. And that means that we may need to have counterfactual AIs or things that can actually monitor AIs because the scale and the scope is too broad for anybody to keep up in real time.
Rob?
We've actually, so to that point, we've hit that point. We got to about 70, a mix of sort of 70 AI tools and agents. we don't have enough data science people to monitor and manage them with the safety and the guidelines we want to, right? Whether it's monitoring them for drift in learning, recalibration, all of these things, you have to do them in a routine manner. So to your point, Jan, one of the things that we've been tasked with over the past few months is, can we find a platform, so an AI platform, to help us monitor the AI that's being utilized and scale our data scientists by using, and it sounds a little facetious, right? AI to monitor AI, but that's the truth, I think, because someone commented yesterday, it might have been you, Shi, that said, in the future, healthcare systems will have, it's not going to be 500. It's probably going to be 5,000. And there aren't enough data scientists across the country to do that, even for a single healthcare system. So we are going to have better monitoring tools, better guardrails, to your point, to be able to do this in a safe manner, the way that our patients and consumers expect us to.
So Mike, what are your top two or three issues that you sold this into Humana and others? What were they objecting to before you went in, and how did you convince them that no, these are safe enough to run in your environment?
You started with the basics, right? It was aggregation of mass amounts of data that their agents were having to pile through for claims, right? So you've got this data just sitting there that you've got to index. Now I've got an AI engine that can go in and go, hey, query 1, 2, 3, and instantly AutoMagic appears in front of the agents now. So it's time and speed of efficiency. So we sold efficiency. We sold knowing what you own too. So a lot of organizations don't even know what's in the back end of their shop. They've been aggregating for how many decades, right? And is it relevant anymore? So relevancy. So there becomes an exercise of, I need to go through and parse through the data that we're holding. Do we even need to hold this data anymore? Most people don't go through that exercise. They hold data just because it's coveted, right? I got it. What are you going to use it for? Why are you holding it, right? So these exercises of, do I need to hold on to this data, in financial terms is what, 7+1? In healthcare, how long are we going to hold this data and apply it to AI bots and agents that make it relevant, right? Because now there's an evolution of data that's changing healthcare. And I think we're going to age out some data. So one of my problems, and I present this problem as an efficiency problem, is you need to go through and scrub your data to ensure that data is still relevant as you present it to this new paradigm shift of being viewed and presented for patient care. As Jan said, healthcare is hard. So you don't make it harder by presenting old age data to this engine that's going to make it relevant again.
Yeah, that's a great point. So very recently, over the last few months, I've written a lot about this idea of operational truth. Like, our assumption is that when we hire humans, we train them to do a job, or they're already licensed to do that job, and then we tell them how they should work in their hospitals and health systems. But we let them talk to other people to really understand the truth of what's going on in your organization. So the truth of your organization is not what you wrote down in your policies and procedures. The truth is what everybody does around you. And as humans, we can tell people are following the rules, they're not following the rules. So that's what I call operational truth in the human world. Well, the problem with agentic AI is that without operational truth in a digital world, it's going to operate on facsimiles of real life. And so to me, that's foundationally a problem. And I think you guys have done that pretty well, all three of you in your organizations, is trying to figure out, how do you get agents to access the data, which is, quote, the most accurate? And we don't even know what the word most accurate, what the phrase most accurate here means. But yeah, and talk a little bit about that, is that what are you guys doing when you go into an organization? What is all the setup that you have to do, or the cleaning that Mike talked about, in order to proceed with agentic AI?
Yeah, actually, I totally agree. That's a huge problem because people, as you guys all know, in healthcare systems, people are not actually doing what they present to you as they're doing. In fact, you could have people going outside the system to access, let's say, a website to get more information to do their job. In revenue cycle, we see that a lot. So how do you discover that? Well, we actually acquired a tool to do that, but we just watch them and see what they do on the computer side. In the reality side, the physical side, it's a little bit more tricky because people don't want to be watched. But it's, like was said in the last session, we are being watched. And so the good thing about that is that we will get a better idea of reality, but also if we can actually have, and to be on a little tangent, if we can get multimodal input, for instance, in the ambient scribe, we can start to develop some of the gut feel that physicians have from watching patients, from smelling patients, from seeing how they talk, as opposed to just transcribing what they're saying. So you could apply the same thing to, let's say, your staff and find out what actually they're doing and why. And maybe that's the first step to is re-engineering your healthcare system.
And so Rob, when you're looking for this platform, this magical unicorn of a platform that does everything, and I'm being a little sardonic about it because specifically, I think that this magical platform in healthcare actually doesn't really exist. Even the biggest vendors in the community, they claim to be a platform, but one of the simple rules about an actual platform is you don't need the platform owner's permission to put software on the platform. So, and if anybody hasn't seen it, that's written up in Mark Andreessen's paper from a number of years ago, in which he described platforms of 4 different types. And whether it's Bill Gates or Mark Andreessen, their idea of platforms is independence, that the customer, like for example, if you're using Mac OS or Windows or something like that, how many have you tried to install software and then have to call Microsoft to ask permission? You don't. You ask your IT team for permission because it's obviously the platform belongs to the company itself. So talk about that and say, well, what are the strengths and weaknesses? And I know you guys use Epic, but you don't have to mention the fact that it's Epic, Cerner, or anybody else. But what would you want in a platform that you'd be willing to buy if it did certain things? What does that look like? And it may not exist today, but somebody could build it.
I think to your point, the pickings are sparse, not just in healthcare, but across all industries.
Yeah.
They're using intelligence or intelligent automation. I think the number one thing we're looking for is something that's that has transparency to it. If you look at, I think a lot about how the FDA has been thinking about AI, and I think the number one thing that they're looking for is transparency into how is the quote unquote the black box actually function. And as we've thought about it, there's a couple things. So we subscribe to a lot of the chai.org. We subscribe to a lot of the guidelines and guidances that they put out. It's a nonprofit organization that was started at Duke, but it's interesting, just on chai for a second. It's got both industry, government, as well as healthcare systems, all 3 of those parties represented in their governance and guidance on how to safely use AI within the construct of healthcare. And so, transparency, testing paradigms. So being able to, that platform would have to be able to actually host our data so that as we bring in algorithms or agents to be evaluated, we always want to test it on our patient population. So prior to working at UPMC, I lived in LA. The patient demographics in Los Angeles County, much different than Western Pennsylvania. And so they have to be, the testing has to be done on your patient data, on your patient populations. And in fact, we see differences in, even though there may not be significant ethnic differences, we actually see differences when we test it on the Pittsburgh metropolitan versus rural Pennsylvania. So there are signals in there. So it's testing the data, it's transparency, it's allowing us to tune the guardrails that are appropriate for each of the agents. So it has to be a tunable platform that can be specific to hosting each of the different agents that you need to assess and monitor. I think those are the 3 things off the top of my head that I think are the most important. There are probably others. I think both Deanne and Michael may be able to comment in from a technical perspective more so than I can.
Yeah, and for those of you that didn't catch it, what Rob's talking about is CHAI. If you just do a search for CHAI, healthcare AI, they have things like model cards, for example, which models you should use in certain areas but not others. And the really interesting part about that is absolutely nothing that is coming from Chai, because it's difficult, not because they're not trying hard, is immediately applicable. You have to take it in, and then you have to begin the governance process. You pull everybody together and say, okay, what do we want to use? So it's a great way to begin these very, very difficult conversations. And so speaking of difficult conversations, Michael, when you guys go into a particular client, where do you start? You said the basics, which I love. So but just we're in Super Bowl week, so blocking and tackling should be the stuff you start with. Don't try to make touchdowns first. Just do blocking and tackling first. What does blocking and tackling look like for agentic AI?
Look, it starts top down, right? Has the board come to you yet? I want you to think about that, right? Because the board's thinking about one thing. Are we going to be competitive? What's revenue look like? Because we hear others are putting this in, they're saving time, money, right? Improving the employees' lives. So you gotta get past the marketing first from the board and ensure that they understand what does AI, agentic AI, and these tools mean for you, and how do you plan on seeing an end game? Do you have an end game for bringing us in, or us coming to talk to you? Because it starts with education. I was at a hospital upstate New York. I started my year last year up there, educating the entire board, president, CEO, all the way down to CMIO, everyone in the organization's in the room. And it really started, the CIO brought me in. CIO said, I want you to come up here and educate our board on what does this mean for us.
What were you struggling with during that education?
Them understanding that they already had AI, but it was called something else for the past 40 years. And that this is the next iteration of it on steroids, and you have more care and feeding you have to do when you take this new version of AI on. And what is it going to look like for your clinicians? What's it going to look like for your patients? What's it like for IT? And then the cost behind that, because there is a cost. There's an operational cost, there's a technical cost, there's a people cost, because then comes the education for your resources. They've been doing the same job for, Gladys has been doing her job for 20 years. You get ready to move Gladys cheese, right? What does that mean for her? Is she going to be able to sustain and keep up with what happens once you put these tools in? So there's a reality check that comes into an organization when you start talking about automation and things moving faster and people getting more data, more accurate data. And so we start with the basics up top of, here, let's start with the board, let's educate you, then the assessment of what do you have, even app rationalization, because people always thought, well, can I tie this in? Or we bought this and this. Then they realize, once we go through that assessment, we own 700 applications? Well, somebody wanted this and that and this and that. And what does that mean when you start tying all of that together? Because once you plug in, this agent's going to go use that, as I said before. It's now a reference tool that you're plugging into. It's gathering information. So our basic starts with an assessment, top down, of understanding and then delivering on, here's the reality of what this means for you. And then we're going to plug into these systems only because this is what makes sense today. All right. So what happened with, ambient listening, right? First couple of docs are like, look, I don't know about this thing, because the vendors sold it as, you're not going to need docs in the next 10 years. Once I plug my AI agent in, docs are going away. We don't even need them in the hospital. That's how it came across. I actually moderated a board feed for one of the organizations where there were doctors and vendors on the same panel. I almost saw a doctor commit murder on stage. It was that ugly when he heard that vendors say those words, because the doctor's like, you're never removing me from the equation here. So we have to educate first with this blocking and tackling, as we call it, and then put a plan in place for them to understand, here's what you're actually going to get. Here's what it's going to be able to do day one. You walk your employees, you walk your patients into this model. You make sure they understand what they're going to see, and then you educate them on how to actually interpret this information in a different way. Because now it's not just about reading, now it's auditory, it's visual. These bots can deliver information to a patient visually, and you don't know that's not a real person. So it's also education around that.
No, I love it. So yeah, and from your, and remember, if you guys have questions, pop your hands up, and I'll get to you. And I want him to continue this one question, and then we'll jump in, grab your questions. So lots of AI talk, lots of places. No hospital is going to say, "I don't want AI." Right? That's a crazy statement. However, given the abundance of choice and the lack and the confusion that's out there, many decision makers are frozen at this moment. And you guys have been doing this for decades, so it's not like you haven't seen other times. So why are lots of organizations frozen, and why are they not being able to make quick decisions? In seemingly because they want AI. Like what's holding them back? And then what do you guys do to help them get over this hurdle of making the decision?
I totally agree. I think that AI is fundamentally different from introducing a new scanner. It's fundamentally different. It's such a large scope that you are frozen because it has such a large implication, not to mention that it's early. And so they talk about the governance thing is still very premature. So what we have to do is actually educate. And I've had exactly the same experience where somebody told me to come and talk to the board because the board was trying to figure it out. And it is not easy. So we have launched actually a new program called Catalyst, which is an advisory service, paid advisory service. But it's well needed and it's in much demand. I would say people have called and said, we need someone to come in and tell us, give us a scoop, not from a vendor point of view, but from a industry trend point of view and where we can expect to be, what is our business judgment on it.
So elaborate on that. What do you guys do when somebody says, okay, love your service, bring it in? What does that mean?
Right. So we have probably about 24 different programs. And so the main program is sort of your road mapping program, your strategic roadmap education. It takes 2 weeks. And so we'll bring in people and it ranges from that to 1 to 2 to 3 day programs to 6-month programs that produce a POC, things like that, where the board can actually see this is possible with what we have. And so it's a bit of convincing, a bit of education, but mostly it's guidance. And I think that's really needed. The difficulty is that technology is changing so fast.
Yeah.
And so what you advise somebody on today is going to be out of date next month. And how do you equip people so they can be resilient and understand what's going on?
No, great point. So I'll take your question first and then Neil's, and then we'll come back to Rob.
Right, so I think you guys mentioned that you've all worked with Agentic AI and you've implemented it. We all know that like when you're talking to someone, there's a different, posture, there's a different sort of punctuation and what have you. And as we, even different industries are implementing Agentic AI, restaurant, and you're talking to someone that's not a someone, right? So my question is, there's different phases of implementation of Agentic AI, right? So maybe level 1, like fielding out, is this just like, level 1 type of scenario, level 2, level 3, not jumping off the bridge might be level 3, right? Where you kind of need to have a human on the phone. Where are you guys in your journey today in your organizations, if you're allowed to share, in that phase? And how are you finessing the language and the humanistic component of your Agentic AI bot or agent?
I'll start with Rob, because we're dealing with people with the first engine we developed for mental health and addiction. And I'm not going to call the name of one of the persons on the team, but they put together the image they wanted to see of the bot. So it came across my desk first. I said, absolutely not. It was a man, right? She said it out loud on the call. I said, a guy did this, right? They're like, yeah, how'd you know? Like, because you would never put that in front of a mental health patient. You got to think about what you're visually seeing and hearing, and you don't put stimuli in front of a mental health patient. So there's some basics around this for empathy. So when we write these engines that are going to be interpreting and how they're going to pull information back and present it, you have to write for empathy. You have to write for being able to interpret pain, right? So you're listening for trigger words. There's a whole lexicon that gets developed behind the scenes when you're developing for mental health of triggers that have to be triggered. And if then trees are then created, so you've got to resolve and go get different types of information to present. And that has to happen in an instant because now you're presenting in real time because you are trying to present a humanistic reply. And so when you start thinking about how to put Agentic in front of people and present not just a menu of items I want to order for dinner, but I want to introduce, you probably need help, and we may need to call 911 or a local area resident person that can help you immediately. That's a different type of engine that has to get created, and it has to be massaged differently, one by the company that's buying it and by the engineers and developers. So our engineers, when we iterate a change, it gets iterated 300 times in an instant. Code used to be like, oh, we got to put a change in, boom, done. No, we have to go through and say, if then scenarios for this change, what will affect downstream in these trees of interpretation back to the person that's going to be receiving it?
Yeah, lots of input required. Neil, do you want to take your question first, and then we'll go to Greg, and then
Yeah, just-
you guys can jump in.
Real quick, I think it'd be great to talk about something we talked offline about last night about contracts and at risk. I think that's a good benchmark to throw out to this crowd. So maybe you could talk a little bit about that.
Yeah, so one of, in general, so one of the conversations we were having last night, and I apply this a lot in contracting, is to, I work with vendors. I prefer to work with vendors who are willing to go at risk in their contracting. To be quite honest, it tends to create a belief in, they have to believe in what they do. They actually have to actually understand how effective the outcome that they're going to generate is, because their income is directly related to the effectiveness of the outcome. And one of the instances I was discussing was around the use of agentic AI in scheduling patients. As some of you heard yesterday, we're implementing sort of a shiny new Epic system. There's actually nothing very shiny about it. And there's a lot of like people in the background that keep Epic running. I mean, I'm talking about end users, right? Because as some of you who have implemented or use Epic scheduling in this particular paradigm, there's a lot of people that are moving between the digital machinations to make it occur. I think it's very high maintenance, very high prone to mistake. It's a challenge. And so I was talking with a company about, could you create agents that could potentially work in the scheduling space? There were some very unique use cases that I was very interested in. And I said, if you believe you can develop that, would you contract at risk? So I think at-risk contracting is something that we've become very accustomed to at UPMC in employing and working with companies. It tends, in my experience, when done well, it aligns the vendor and the healthcare system into a partnership, because you're aligned, you have shared goals of an outcome that potentially will be positive for both of you. And that's the ultimate goal, I think.
Yeah, and I could just add, based on something you said last night, real quick, by at risk, you don't mean the old fashioned at risk, like time, budget, schedule, incentives. You're talking about the whole thing.
The whole thing. No, yeah, nothing up front, right? It's the whole thing. You're right.
Oh, great point. Greg?
Throw out a couple of statistics from Ross Sullivan. We do a lot of research. We did a survey across like 11 industries, 2,300 users, 19 countries, right? So looking across industries. We've implemented AI on at least one business function or use case. Healthcare, 52% industry average is 40. So healthcare, for one of the first times, is ahead in terms of technology deployment. And
Could you just take a quick look at your mic? Greg, your voice is not coming through on the mic.
On the agentic side, there we go, user error. Be careful with agentic AI. On agentic AI deployment, healthcare, at least one use case, healthcare was 47%, all the industry averages to 31. So again, on agentic, healthcare is ahead of other industries. This is a global survey. One of the things we talked about in sort of our research and looking forward in this is multi-agent systems. I'm sure panel has discussed this in at least Yen probably has within his organization, and looking at how that could be applied in healthcare. Most of the agentic systems in healthcare are probably administrative scheduling, Rob, you just mentioned. But, if we identify a care gap, somebody could, stimulate outreach to that person. Somebody could, or an agent, could schedule. An agent could even order a test, or based on something that comes back, order a test. There's these multi-agent systems that could be used in multiple ways to bring information back to clinicians on evidence, diagnosis, et cetera, just information, not decision-making. How far are we from that? Obviously, healthcare's toe in the water with agentic AI. How far are we from those kind of multi-agent systems, even at the administrative level?
Well, actually, it's a reality today.
Mhm.
The question is, what do we want agents to be allowed to do? I guess that's the question. And I think there's a lot of discussion about the level of autonomy that agents should have. And, it's interesting. Yesterday, I think I heard a story about agents talking to agents. and the latest exploit right now, I just read about it today, is a lateral movement, which is where you use an administrative login, use an agent to contact another agent and fool it into thinking you have more privilege than you do. And so when that kind of stuff happens, how do you monitor that as a human being? You can't. You have to use your own security agent. And so you can see a whole team of agents. Then how do you manage them so they all work together and not working at odds? I think it's a challenge, and it takes a bit of deep thinking and strategizing. And so the question is, what is the risk level for an agent? What kind of risk level? Obviously, the risk of somebody who would say they want to commit suicide is very high risk. In fact, years ago when I was at Kaiser, that's one reason we didn't put out a social media platform. Because if somebody were to say that, we'd be responsible to react, and we may not have the resources to do it. So there's a lot of implications, and I think healthcare systems are rightly thinking about it right now. There's a lot of talk about AI governance and AI management, but it's still very early.
And Greg, our next panel is actually on cybersecurity, but what I wanted to think about first was, there are lots of organizations that have moved their identity and access management policies into code. So I would say, if your organization, say you're using a manager like OPA. OPA means Open Policy Agent. It's not an AI agent. It's a policy language that you write code in to tell you who's allowed to see what. So there are three groups of organizations. Organization style number one hasn't thought through coding in technical terms their policies about access management and control and who gets to log into what, et cetera. Those groups, holy cow, if they're doing multi-agent, don't go to that hospital, right? Now, there is a second group of hospitals where they've started to do identity and access management. They understand how to enforce and manage policies in code. That team should start the experimentation process. And then there's a third group where not only do they have all that, but they've actually started experimenting with multiple policy agents in, Yan and team like to call it the administrative AI model rather than the clinical AI model, which is a fantastic place to start. And the real problem is that nobody wants to say it out loud, but until you execute these agents, nobody knows how they're going to interact. And so if you're waiting to say, well, I need to learn everything about agents before I implement my agents, you're never going to implement your agents, right? And so that third group is a true learning organization where they realize that there is no agentic AI unless you actually put it into practice and you have operational truth mechanisms such as identity and access control, these policies, et cetera, that are, so think about this idea of policies as code. We don't have very many organizations that put their policies as code because they rely on the village of humans to know the policies and coordinate and communicate. And in most healthcare organizations, we trust the humans because they're empathetic, they know what they're doing. We don't think that they're going to go do things illegally on their own. But in those organizations, we have not put policies into code. And if you don't have policies as code, I don't mean policies in a Microsoft Word document or policies in a spreadsheet. I'm saying policies as code. There's actually new coding languages now that allow you to put in laws as code, put in blockchain checking to make sure somebody's allowed to do something or not. I'd love for you guys at Frost to really, I would love to see some articles on that, focusing on just that two topics. One is, what are you doing about policies as code, number one? And number two, how the heck do you establish for agents operational truth? And if you don't have policies as code and you don't have operational truth, you're going to kill somebody. It's just a matter of time. I mean, it's just no way to get around it. And then we're going to have to learn through our way of doing that. So we've got a few more minutes. Was there another question? I think, or Rob, or you wanted to say something? No? Okay. I thought there was one other question. If not, let's just expand on this last topic, since we have just a couple minutes to finish up before we do the cybersecurity talk is, what are you guys seeing in terms of sophistication of moving to these kinds of things like policies as code and getting more to helping systems establish operational truth such that we can now build on them. So Mike, you can talk and then we'll let Rob finish up after Yan.
No, policies. I'll give you another out of industry example here. So the most of Las Vegas and their casinos have already started using agentic AI. They've come to us to say, hey, we need risk profiles on these players. How about that? You got to think, one of the largest playgrounds in the world have already figured out I can put a risk profile on the top 2% of players that come to our casinos, and I can get a mental, physical, and financial risk portfolio and profile put out on them. And then I risk rate base how I'm going to give them credits to play at our casinos. So now they're going to get a mental health risk score based on win-loss over the courts. Yeah, think about that. You apply that, bring that back to healthcare. I've got patients that are constantly coming in for cancer treatment, coming in for growing morbidities across the chasm of healthcare. And what if they started risk scoring based on your ability to pay in rural areas? That's what these agents are going to be able to do in real time. I won't have to have someone take an insurance card and check to see when they were last here in the system and do they have current insurance. We're already doing prior authorization. So now it's just a matter of, hey, in these rural areas, is my hospital going to be profitable? The actuary is actually this new agent, right? So when you make policy as code, that code is saying, hey, this population, this hospital, probably in the next 3 to 5 years, non-viable based on the age of the population, because it's going to know that, right? It's going to go out and get that information. When I say these agents are going to go and get any information to solve the problem, it's going to say, is this hospital going to be profitable in this rural area over the next 3 to 5 years? Should we invest? We're going there with policy as code because it's going to be written to tell me what a potential outlook in future can be for health systems.
Nice. And when you guys were doing, you can do a lot with even with the RPA starting point. It's really nice that your agents build on your decades of experience of RPA, because you almost have to start with RPA to do almost any agentic.
Mm-hmm.
So talk about that for just a brief second, and then we'll turn it over to Rob. Is that what have you guys learned, and what can you just kind of like give as advice to folks here who want to make a decision? What do you have to do to quickly get started? Because unless you get started, there is no learning. And if there's no learning, there's no production.
Yeah, you're right. The RPA part of our market is still very vigorous because, to be honest, rules-based deterministic is safe.
Yeah.
You know what something is doing and why it's doing it, and you just defined it. The framework for AI agents is still developing. In fact, the EU AI Act just passed a deadline without being able to enforce it because AI is changing so fast. So be able to write into code is great, but then you need an AI agent to write it into code so it changes with the development of AI. So I think right now, we just a figure in 2026 so far, we've run 1.8 million AI agent executions so far. That's across all industries. So it can be done. It's just that healthcare is very cautious, and there are a lot of structural impediments, but it takes education, it takes medical school retraining, actually. And it takes, I get a lot of calls from physicians who are wondering about medicine, the future of medicine. And that's not a trivial issue. There's real issues coming out where areas that we thought we would always be useful as a physician are disappearing. And so what is our role in the future, right? So instead of doing, we have to manage a team of automations or AI agents. That could be very exciting to some people. scary to others.
Yeah, and by the way, Megan did a great interview with Yen here just a couple of weeks ago on Health Impact Live. That's worth hearing because he goes into a lot more detail about this stuff as well. So Rob, last word, the answer. If you can comment on Greg's point about that Frost and Sullivan report. Why do you think finally healthcare is ahead of some others in this area, especially talking from your perspective at UPMC?
We've got a lot of human processes that I think can be standardized that are away from the clinical environment, to be clear.
Yeah.
So I think that if your report went one layer deeper, it would probably also state that where that automation, where that's being utilized at this time for the agentic use is not at the frontline clinical space. The example I gave at the front end when we started this session about clinical decision support, we are not using that in the wild today, just to be clear. We've got about 50 physicians, mostly informaticians, who are using that to learn. But to your point, Shahid, we don't have the coded guardrails in our system yet to make sure that it can be used safely. And part of what we're trying to understand, and I think this is the challenge in the clinical space, is what are the actual guardrails we need? I think there's many that we can go to a whiteboard and we can list out the top 20, but there's probably 100. And we actually need it to work within the clinical environment in a manner there where it's expressed from the clinicians to be utilized clinically so that it can churn through all the potential use cases in a real-time space. And then we harvest that to understand then the types of guardrails that we need to create, which end up being that policy and code as you talked about.
Yeah, fantastic. Let's give a big round of applause. I think panelists here. And the main learning here is get started.